and thank you, Dr. Deeptina, for giving me this opportunity to present this topic of surgical management of fibroids. And I think in gynecology, this is the most favorite topic for me. And I love doing myomectomies, and I've done from open, laparoscopic, hysteroscopic, vaginal, myomectomy during cesarean, as well as robotic, which is just new for me too. And none of the fibroids are the same. No two patients, no two myomectomies are the same. So this involves a lot of clinical decision, how you should tailor your particular surgery for that particular patient so that it's beneficial for the patient. So we know that for fertility preservation, we recommend myomectomies, but there is a recurrence rate of almost 15 to 33%. And this is much more whenever we have dealing with patients who are having multiple fibroids or they are seedling fibroids. They are the patients who are going to recur more. If a person has a single large fibroid, the chances of the recurrence is much less. And almost 10% eventually lands up in hysterectomy. So the key consideration for the surgical management is to tailor the approach to find the suitable candidate who requires a particular type of surgery. Patient age and symptom profile is the utmost importance. Whether the patient is adolescent, patient is a young adult, she has completed a family, she is menopausal. So we are going to choose our patients according to the age as well as the symptom, what she's having. Is she infertility or is she having heavy menstrual bleeding? Fibroid characteristic is also very important. Size, number, location of fibroids help us to guide the optimal surgical approach and the technique. And the desire for future fertility. Some people may be very well off with hysterectomy at the near the perimenopausal age group, but still they have completed families, but still they don't want the uterus to be out. They want only the myomectomy. So we really have to tell them, okay, if it's a single fibroid, we can do it, but if it's a complex fibroid, multiple fibroids, she'll be better with the hysterectomy. So we really need to see what the patient is looking for. And the available resources and expertise should always be there whenever you are considering these patients for myomectomy. So since the time was short, I couldn't do the most of the literature review. I got hold of this recent guidelines which was published in 2024. It is published in two parts. Part one is dealing with abdominal myomectomies, which deals with laparoscopic, open, as well as the robotic. And part two is the hysteroscopic myomectomy. These are very good online free access journals. You can just go through all the, basically in detail. The whole document is available with you online. It's a free access. So this is published in 2024, both of them. So the indication of myomectomy is basically the symptomatic fibroid. Heavy menstrual bleeding, not responding to medicines, having pelvic pain or pressure because the size is too big, or they are having infertility or having a recurrent pregnancy loss. And the goal is to preserve the uterus and to preserve the fertility. So myomectomy is preferred over hysterectomy when fertility or uterine preservation is desired and is technically feasible. That is also very important. So there is a classification by FIGO, 0 to 8, we all know. 0 to 2 is submucosal, 3 to 4 is intramural, 5 to 7 is subserosal, and 8 is cervical or a parasitic. ESG classification is for hysteroscopic, for submucosal fibroid, for hysteroscopic myomectomy. It's 0, 1, and 2. So this is, we all are very well basically know about this classification. This is ASGE classification, which is 0 is a pediculated fibroid, 1 is basically a fibroid which is more of the 50% or more in the cavity and less is intramural. And step 2 is basically the fibroid which is more in the intramural than in the submucosal component. So along with this, there is a step W classification or the Lasmer classification. It's a site, depends on the basically size of the fibroid, the topography of the fibroid, whether it is low in the cavity or high in the cavity, it's near fundus or it is towards the internal os, as well as the extension of the fibroid. What the base, does it covers half of the cavity, less than 1/3 of the cavity, or similarly the broad base which is there in the endometrial cavity, along with the penetration, the intramural component, as well as whether it's on the anterior wall, posterior wall, or the lateral wall, because all this describe us about whether we are able to successfully do the hysteroscopic myomectomy or not. I'll come to this in detail later on also. So the route of the surgery depends. FIGO 4 to 7 types, intramural or subserous. We have to approach it through abdomen. Okay? Hysteroscopic myomectomy is for type 0 and type 3. For type 8, cervical fibroid, vaginal approach is there. I have not covered it, but I will just be saying it. Open myomectomy, we all know. We are all well versed. It's a gold standard. It has been in practice for more than 200 years. And this provides easy access to fibroids. There's no morcellation required. You can remove the fibroid all intact. There's a better control of bleeding. But the cons are, it's a large incision. Cosmetically, it will be a larger incision, which will not be acceptable to the patients nowadays since we have laparoscopies available. Obviously, it requires a longer hospitalization, considerable higher levels of post-op analgesia, increased morbidity, and most important, adhesions. Whatever means you try to do a myomectomy in open cases, adhesions are always more when compared to laparoscopic or robotic approach. So they have seen that the adhesions are almost to the tune of 55 to 93% in open cases as compared to laparoscopy, where it is only in 11.2 to 16.7%. So preoperative evaluation is important because we should know what we are dealing with. We need to have an imaging where we can see where the fibroid exactly is. The FIGO classification, ESG classification, we should be able to do with our imaging modality. And MRI, especially if it is a complex fibroid, it is going in broad ligament, it's an irregular uterus, it's a large fibroid, we need to see the course of the ureter as well. So MRI is very important for larger fibroid. Obviously, these patients are anemic and they need to be built up. And preoperative fibroid mapping and assessment of the number, size, and location of the fibroids is very, very important, and their relation to uterine cavity, the tubes, and their vascularity is also important whenever we are dealing with myomectomy. I just want to tell about one case I had dealt with. Patient came from Aligarh to me. She had a phalansteal scar. She was recently married for 6 months, and she had a big fibroid of about 5 to 6 centimeters on the ultrasound. She said in Aligarh, she underwent a surgery. They have opened me up, but they couldn't see the fibroid, so they just closed me up. And she was suffering with a severe heavy menstrual bleeding. And she was told that if bleeding cannot be controlled, you have to undergo a hysterectomy. This is so devastating for a newly married woman. When she came to me, she had a big submucous fibroid on diagnostic hysteroscopy, and it was quite big, 5 centimeters. I put her on danazol for 3 to 5 months, and then it shrank down almost 30%. And then I did a hysteroscopic myomectomy. Subsequently, she had, conceived, and she delivered by cesarean. She didn't come to me, but she called me from Aligarh and, let me know. So this is so important, especially submucous fibroid. It can be missed when you are just going in for surgery without even knowing what are the imaging findings are. So abdominal myomectomy is indicated for large intramural fibroids. And in one study, they have said that if a fibroid is more than 10 centimeter in size, it is better to go for open than going for a laparoscopic route. But it depends on the surgeon preference. Some people can even do larger, bigger fibroids, more than 15 centimeter also by laparoscopy. So, but we should be very cautious in fibroids which are more than 10 centimeters, multiple intramural fibroids, and the history of prior uterine surgery. If a fibroid is 26 to 28 week size, you will not be going for laparoscopy. You will be going for open, because otherwise the surgery might take longer, 3 hours, 4 hours. And there's going to be a big scar on the uterus, and stitching it up will be difficult. So pre-op preparation has already been told. ESG says that they are the GNRH analog which were classically used for size reduction as well as building a patient for surgery, is much better as compared to GNRH antagonist and nulliprostol acetate. So pre-op GNRH reduce both uterine fibroid and fibroid volume, improve HB levels, and reduce the perioperative blood loss, although at the expense of increased estrogen deficient side effects as hot flushes before surgery. Reduction in nutrient volume may also increase the feasibility of minimally invasive laparoscopic approach and reduce the presence of intra-abdominal adhesions. So if we are dealing with a very large fibroid, we can downsize it with GnRH analog. If we are going for open myomectomy, we can convert a midline to a phalansteal scar, as the uterus size will be lesser. So if we are giving a preoperative GnRH analog, open myomectomy is better if it's a big fibroid and you're reducing. But for laparoscopic myomectomy, it poses more challenge. Because the fibroid becomes very soft, the pseudocapsule, the demarcation becomes a little difficult. So it becomes a technical difficulty. But in submucous fibroid, it is useful. It decreases the endometrium, it makes it very thin, decreases the size of the fibroid to even 5 centimeter type 2 fibroid, we can take it out even hysteroscopically if we are priming it with GnRH analog. So that is the advantage. Ulipristal acetate was, RCT was started with GnRH analog, but because of the side effect of the liver profile, and it was not as effective as GnRH antagonist, so it was not, study was not concluded further. So ESGE says that there is no routine recommendation to GnRH analog pre-treatment. It is up to the surgeon, up to the clinician, what is best for the patient, as individualized treatment is better. Whenever it is done only for size reduction and to time the surgery accordingly, especially in the hysteroscopic route, and we should discuss the cost and side effects. Whenever we are doing for abdominal myomectomy, be it open, be it laparoscopic, be it robotic, we have to use methods and key principles which are same for all the methods available. We have to decrease the blood loss. And how to do it? Either we use a tourniquet, or we tie up the uterines, or we use vasopressin. Vasopressin is very much useful and it's very rampantly used, especially in laparoscopic and robotic practice. Now even in open myomectomy, even I had used vasopressin and I found it very, very useful. Prior to vasopressin, when we used to do for myomectomy, we used to do the Boney's clamps, ligate the uterines temporarily by pressure or doing a tourniquet, but still the blood loss was more. With vasopressin, definitely the blood loss is much less, but we should be very much, used with caution in patients who are hypertensive or cardiac patients, because they can have severe hypertension. The incision should be such that the fibroid can be taken out easily. The size of the incision matters. If you're just going through a small incision, you'll be fiddling, you'll be going in wrong planes, and you'll be landing up in more blood loss. So the incision should be elliptical. It can be even oval. For a large fibroids, we can even give an oval incision and take out the fibroid. Dissection in layers. Be in the pseudocapsular plane. Because all the blood vessels, there is no feeding vessels. You can locate whenever you're doing a myomectomy. It comes through all the walls, every side. Pseudocapsular is the region where it is least vascular. And we should close the incision layer by layer, in 2 layers, 3 layers, 4 layers, but properly, avoiding dead space. This is very important. And this is the main challenge in laparoscopy. Closing the incision laparoscopically, it's a big challenge. Whether in open, it is easier, we are well versed, but in laparoscopy, taking out a myoma is much easier, but suturing is very, very technically demanding. So this makes the robotic much easier because the suturing, because of the wrist-like movements of the tips of our scissors and the needle holders, it becomes very, very easy. Prefer laparoscopic or robotic rule when expertise as well as resources allow, as compared to open myomectomy. This is the standing by ESG in 2024. What are the anti-adhesive strategies we should be using? ESG says that short operating time. Plan your surgery well based on patient's symptoms, patient's imaging, and you should go in after a thorough planning where you will give the incision, how easily accessible the fibroid is, so that we can finish the surgery in a shorter possible time. In open myomectomy, the whole of the serosa surface is exposed to air, so there's more adhesions. In laparoscopy, it is closed space, so the serosa surface is not going to dry up that much. That's why the adhesions is less. But especially if you are going in for open myomectomy, shortest operating time is always better. Meticulous hemostasis is important because if there is a lot of bleeding, it incites the adhesions later on. Improve intra-abdominal environment by humidifying the CO2, whatever insufflating we are giving. If we have a facility to humidify it, it will be much better. And use a lactated ringer solution for irrigation whenever we are doing for open myomectomy. Just irrigate it for some time so that the serosa remains moist. Barrier agents have also been used. There are studies, but all the studies are very small studies with no clear benefit available. But ESG says that the barrier agents which have been most found to be useful are oxidized regenerated cellulose, polytetrafluoroethylene surgical membranes, hyaluronic acid products, which may be beneficial in reducing post-operative adhesion formation. However, the robust data is lacking. But especially nowadays, since we are using with barbed sutures, we should not leave the barbed suture exposed to the intestines, because they can go and get stuck there, and later on patient can land up in paralytic ileus, can land up in intestinal obstruction also. So it's always a best practice whenever you're doing a barbed suture, use a serosal technique of closure by baseball technique or other technique, whatever you're using it, but so that minimal serosal exposure of the thread is visible, and cover it with a thin, oxidized regenerated cellulose, that gel foam or the film if you have, Surgicel, that should be applied. So minimally invasive approach, the surgeon should be having adequate training and a volume of cases, equipment and infrastructure should be available. Fibroid burden, size and the anatomy should allow for safe laparoscopic and robotic access to the fibroid. It should be so huge that laparoscopic access has become difficult. So open obviously remains appropriate where there's a large fibroid, high fibroid burden due to the multiple big fibroids, dense prior surgery, severe adhesions or technical constraints. So ESG encourages laparoscopic or robotic as first line abdominal options when feasible, with open as a valid alternative when minimal invasive approach are not suitable. So when we compare laparoscopic versus robotic versus open, access laparoscopic port in laparoscopy, robotic ports in robotic. With in the robotic, there are all 8 mm ports which are there. You use 4 to 5 ports. 3D visualization and wristed instruments gives a far much better, easier, access. And ease of doing surgery is very much there in robotic. Open myomectomy, it can be long midline if it's a huge fibroid. Otherwise, up to 24, 28 weeks, we can do with fan and steel incision. So ESG positioning, I have already told, preferred minimally invasive option where feasible. And robotic is included under abdominal myomectomy only as a minimal invasive route. And open myomectomy is recommended when minimal invasive route are unsafe or impractical. Operative time is obviously, it's minimal with open myomectomy. Laparoscopic, it's little longer, and robotic, it depends on the team. It may be equal or maybe a little longer. Blood loss and transfusions, blood loss is higher in open myomectomy, also because we are dealing with larger fibroids, multiple complex fibroids by open. And laparoscopic myomectomy, blood loss is less, and robotic blood loss is very, very less because we are coagulating even the finer vessels. Post-op recovery, obviously shorter hospital stay with laparoscopic and robotic, and open myomectomy, it's a longer recovery. Convergence is small in laparoscopic, robotic is very, very less. In fact, I've done 8 cases of robotic till now, out of which 2 were myomectomies, and both myomectomies were like more than 15 centimeter fibroid in a young patient, 35-year-old, one was 28-year-old, both unmarried, obviously wanting pregnancy later on. So if I would not be going for robotic, I would have taken it for open myomectomy because they were big fibroids. But with robotic, it became quite easy and manageable. And they went on with very tiny scars. So that's the advantage. Cost obviously is least with open myomectomy, but maybe a little more if there are more number of hospital days. Highest cost with robotic. So abdominal myomectomy route, first line abdominal route is laparoscopic or robotic when feasible. Preferred role for robotic is complex anatomy, narrow pelvis, or surgeon early in the laparoscopic curve. So people who are moving from open surgeries to robotic with a lesser laparoscopic curve, they can do much better with robotic than with open. And those who are advanced in laparoscopy, obviously it becomes very, very easier for them to shift to robotic. So 3D vision and wristed instruments, I've already told. Open remains valid, large fibroid, dense adhesions, and resource settings. These are my cases. I've done these big myomas, did a myomectomy. This was a young 24-year-old girl where we did a myomectomy. And Dr. Manju, I think this is a Kalashnipak patient. She was a 24-year-old with heavy menstrual bleeding, unmarried girl. We did an open myomectomy because the uterus was about 24, 26 weeks size, and she was a thin patient, and whole abdomen was almost like a lower half was full of fibroid. This was the case. This was another interesting case. It was a prolapsed submucous fibroid with severe anemia in a 40-year-old woman who presented with AUB and severe anemia. We have done a mapping. There was only a fibroid which was coming from the cervical canal, just below the internal os. And we could do vaginal myomectomy, and it was, daycare procedure for her, and she was relieved. So vaginal myomectomy is also very important. This was the one laparoscopic case. This is a very interesting case. That's why I kept the slide. 39-year-old, she presented to me previous to cesarean. She had 2 children. She had a posterior wall submucous fibroid, and she was bleeding heavily. And she said, "कि मेरी hysterectomy कर दो." मैंने कि fibroid है, निकाल सकते हैं आराम से. So she's only 39 years old. Then she went ahead for laparoscopic myomectomy. There's a posterior scar. It was a submucous myoma type 3. Type 2 to 3 fibroid. So 5 centimeter fibroid, which almost less than 1/3 was the submucosal component, rest was the intramural component. I did it laparoscopic myomectomy, and after surgery, 6 months later, she conceived for the 3rd time. Meanwhile, she had lost 1 child. She continued with the pregnancy, and she delivered by cesarean section. And when I did the cesarean, posterior surface, it was absolutely clean. There was no adhesions at all. So I was pretty happy about it. So advantage of robotic technology over conventional laparoscopy is absence of tremor. Especially when we are aging, so we have tremors, then that can be negated in the robotic. 3-dimensional image, superior instrument articulation, downscaling of the movements, and comfort for the surgeon and faster operating learning curve. It's a faster. In laparoscopic myomectomies, 100 laparoscopic myomectomies. In this, it is only 50 hysterectomies and myomectomies. So this was the images. This is not my cases. I couldn't get the recording of my cases. This was just from the teaching videos. I have taken a still. This is the angulation of the scissors. It's very much useful. There's a tenaculum which is available to catch hold of the fibroid. And we can really very nicely, we can see and we can suture. So ease of technique is there in this robotic. So choice of lap versus robot versus open is individualized to the patient depending on the anatomy, fibroid complexity, surgical skill rather than a rigid hierarchy. How to retrieve the tissue? Power morcellation came when we started with laparoscopic myomectomy. We were all very happy doing a morcellation. But then comes peritoneal implants, then there comes risk of malignancy dissemination, and people have gone back from laparoscopic to open, especially in the large myomas. In-bag morcellation is available, but it's tricky, it's a little costly, but not that much costly, and the cost, I think, is less than 5,000 one bag. But it requires a little more technique to get in-bag morcellation. So another techniques come up, how to remove it after we do a laparoscopic myomectomy. Some people are retrieving it through pouch of Douglas. Some people are enlarging the umbilical incision and taking out from there. And some people are doing a Chinese roll technique, just slicing it off spirally so that you can take it out in a form of a ribbon. So these are the techniques which are available to retrieve the tissue. Or you can just do a mini laparotomy. Or if it's a large fibroid, obviously going to take much longer time for morcellation than doing a myomectomy, better to go for an open myomectomy, it depends. So risk of malignancy is there in sarcomatous change is very low. It's 0.14%. In various studies varies from 0.49 to 0.056%. Age-related malignancy risk decreases. It is more when a woman is less than 50 years than when a woman is more than 60 years. There is limited data from small RCTs which does not show significant difference in safety in duration of morcellation between uncontained or in-bag morcellation approaches, because the risk of sarcomatous change is already very low. But the problem of peritoneal implants is there with power morcellation. So we need to counsel the patient or opt for a technique of in-bag morcellation. Now coming for hysteroscopic myomectomy. Type 0 pedunculated, type 1 less than 50% intramural, and type 2 is more than 50% intramural. Type 3 is completely intramural and it just contacts the endometrial cavity. So main indications are heavy menstrual bleeding, infertility, recurrent pregnancy loss, and some mucosal fibroids. So this is the step W classification, where we score the particular fibroid, and out of that score we determine the feasibility of doing a hysteroscopic myomectomy. For practical purposes, any fibroid which is less than 3 centimeters, which is lower in the cavity, not near the fundus, not on the lateral wall, is easier to take out. So all these dark blue are a score of 2 or higher, and light blue are a score of 0. So those light blues are easier to take out and blue ones are difficult to take out. So how do we classify? Size, step is size, S is for size, T is for topography, E for extension of base, P is for penetration, and W is for wall. So less than 2, 2 to 5, or more than 5, and we score it them. 0 to 4 is less complexity in hysteroscopic myomectomy, can be done very easily. 5 to 6, it's high complexity. Consider JNRH analog preparation prior to surgery, and two-step hysteroscopy. I had another patient who was around 35 plus. She was a previous one cesarean and had one child, and she was used to bleed very heavily. She had a submucous fibroid and she wanted a hysterectomy because she कि एक बच्चा बहुत है और नहीं चाहिए, आप मेरा यूट्रस निकाल दो. मैंने कि आराम से hysteroscopy से निकल जाएगा. We'll do it, but we can do it in 2 settings. It was a 5 centimeters type 2 fibroid. It was more in the type 1 to 2, more in the cavity and 1/3 in the intramural. So I did one setting, I did with the resectoscope, with the resectoscopic scissors I take out the fibroid. 1/3 component I couldn't remove because there was a large big one. I had already counseled her previously I'll do a repeat check after 3 months and then do it. After 3 months she came back to me, there was a sessile fibroid very nicely coming up. So with that, resectoscope was not available. So I did with scissors. Scissors से वो सारा 1/3 निकाल दिया. After the patient conceived and she delivered by cesarean, our अंदर की cavity was absolutely new. There was nothing, no adhesions inside. I was so happy about it. So we should know which patient, how to counsel. Which patient needs a JNRH analog. So she was fitting in this score of 5 to 6, where JNRH analog is useful, or we could do a 2-step hysteroscopic myomectomy. 7 to 9, consider alternative to hysteroscopic myomectomy. So in the case which I had just shown, laparoscopic myomectomy of a posterior wall, that was a fibroid which is bigger, and it was more in the intramural than in the submucous component, 2 to 3. That was better off with doing a laparoscopic myomectomy. So for type of fibroids 1 to 2, slicing technique is recommended over pure morcellation. Now pure morcellators are also available, which just like they just chew the fibroids, you know, rotate and then chew. Those are good for polyps, but not good for fibroids because fibroids are hard. We need to really either have an open, cool electrode is also available, cool loop, which, you know, sort of a small knife which just slices off. People use it near the base of for the myomectomy, or the electrosurgical ones. Electrosurgical also varies from 15 franc to 26 franc, and they are available in monopolar as well as bipolar. Bipolar 15 franc will be ideal because you will be using only saline because of bipolar, and you will be not have to dilate too much because it's 15 franc, it's narrower, but the cost is more because it is very delicate instrument. Bipolar 2 के 3 के ज़्यादा नहीं चलता, वो टूट जाता है, काम करना बंद कर देता है. Monopolar, it's more sturdy, especially the 26 franc, which is quite sturdy. It can last up to many cases, but we need to use glycine. So we have to be very sure that how we are using it and what type of fluid we are using it for distension media. Whenever we are using monopolar, we are using a glycine. Whenever you are using bipolar, we are using saline. So we have to maintain the fluid balance and monitor the input and output. How to do it? Ideally, myomectomies should be done with a hysteromat. An endomat, I showed in my previous slide, there was like a intake of the fluid as well the output of the fluid is all monitored, and pressure should be less than mean arterial pressure. Otherwise, fluid overload chances will be increased. So start visualization at 75 to 80. If you're comfortable, do it at that. If you need to do it more, go more, but maximum should be 120 millimeters of mercury. You fix it on the histomat. Fluid deficit is less than 2.5 liters saline or 1 liter glycine. If it is more than that, stop. That is why two-step is important whenever you are doing a larger submucous fibroid. So plan multi-step resection if large type 2 fibroid, insufficient myometrial free margin, or risk of fluid overload or thermal injury. This is also there. So whenever we are using an electrode which is activated, we should not go beyond the endometrial. Whatever fibroid is protruding inside, just slice it up flush with the endometrial lining. If you're going beyond, you can go through and injure bowel. So this is type 0 fibroid. This I have taken it from the ESG only. This is not my slides. Type 0, almost the whole of the fibroid is in the cavity. Type 1, more than 50% in the cavity. Type 2, more than 50% is intramural, less than 50% in the cavity. So this is before resection and after resection. And this is another technique where they use a electrode, 5 franc electrode, very fine electrode which goes through the operating channel of the operative scope. Dissectoscope is not required, so thinner diameter, we can go through the cervix easily. So what they do, they just take an incision just at the base of the fibroid and enucleate the fibroid. This is fibroid before and after resection. This is a cavity, you know, and you don't know how deep you can go. So whenever you are going below the endometrial cavity, do it bluntly without activating the electrode. पहले उन्होंने incision दिया electrode से, फिर उसको lift किया blindly, मतलब without the cautery, and then just take out the fibroid. So it's the least invasive approach to myomectomy. No scar on the abdomen, and preserving the integrity of the uterine wall. Patient will not be requiring a cesarean also because there is no incision and suturing over the uterus. It's safe and effective in treating heavy menstrual bleeding. The success rate of 70 to 99%. I love this submucous myomectomy. This is the most, useful, most promising surgery for the patient. So the key recommendations are preoperative assessment using imaging and or hysteroscopy is key. Importance to characterize the submucosal fibroid for a planned hysteroscopic myomectomy, including patient counseling, likelihood of multi-stage procedure, need for medical surgical preparation, and selection of viable technique and appropriate treatment. Automated fluid management, the hysteromat, should be used to maintain intrauterine pressure which is steady and visualize and monitor fluid deficit. Size and intramural penetration of the submucosal fibroid are the main factors, and consider when deciding about the best surgical approach, either electrosurgical or hysteroscopic morcellita techniques, or slicing off and by cold loops, how you are going to go for myomectomy, especially near the cornu, near the fundus. For the beginners, near the internal os are better. Don't take the challenging ones which are near the cornu or near the fundus. Consider post-operative imaging and outpatient hysteroscopy to assess the completeness of the treatment, and intrauterine adhesions may be required after 3 to 6 months if you feel that there might be an intramural component which can pop up, so you can do a check hysteroscopy 3 to 6 months later. What are the pitfalls and safety of myomectomy? Hysteroscopic pitfalls are over deep resection into myometrium and penetration or perforation of the uterus and damaging the viscera. Ignoring the fluid balance limits. If you're using more than 3 liters saline or glycine and you don't know how much had come out, and patient may land up in pulmonary edema, which can be detrimental and life-threatening. Trying to complete a huge type 2 in one step. This is another mistake which people do. Abdominal pitfalls, if there is inadequate hemostasis. If there is poor myometrial closure and underestimating the uterine fragility after multiple fibroids. Complications of abdominal myomectomy, we should all know that bleeding and transfusion requirement may be there. Damage to visceral organs or structures if they are associated with adhesions or distorted anatomy, especially the ureter can be damaged while there is a broad ligament extension of the fibroid. They might require hysterectomy if the bleeding is not controlled. Febrile illness is very common after myomectomy, especially open myomectomies. On day 1 or 2 of surgery, they usually have some pyrexia. Pelvic abscess formation can be there, paralytic ileus and bowel obstruction can be there, even thrombosis can be there. If you're going for a big myomectomies, you should plan to give thrombolytic therapy also. Delayed complications like adhesion formation in the long term is a common occurrence after myomectomy that may cause chronic pain, bowel dysfunction, and subfertility. So there is factors for major complications where uterine size, more than 20-week size, and removal of 10 or more fibroids, and operations requiring a midline incision. Fertility and post-myomectomy counseling is very important. Abdominal myomectomy improves fertility in the selected intramural fibroids affecting the implantation or preventing the loss. Counsel on uterine rupture, risk in pregnancy. Advise waiting 3 to 6 months after large intramural resection, especially in those where the cavity was opened, more liable for rupture. May need LSCS if there is a concern of scar dehiscence of uterine rupture and higher risk of abnormal adherence of placenta in case of large and deep myometrial incision. Hysteroscopic myomectomy normalizes the cavity in type 0 to 2 fibroid and improve the fertility outcome, and patient can plan conception even in the next cycle. So surgical approach, it varies for laparoscopic and robotic. Suitable fibroids, preferably less than 10 centimeters, fewer if multiple, and experienced surgeon. Techniques, vasopressin injection, pseudocapsule inoculation, multi-layer suturing, anti-adhesion barriers, for example, hyaluronic acid. Open, large, multiple cervical fibroids or broad ligament fibroids. Phalangeal incision better, give traction and counter traction, and serosive closure should be proper. Hysteroscopy with submucosal, Figo 0 to 2 are the indications for surgery. Two-step if there is a large type 2 fibroid. So there are other minimally invasive and emerging techniques. There's the uterine artery embolization, MR-guided HIFU, endometrial ablation. These are still yet to be established. Mostly are doing very small centers in small number of patients. So we should report all fibroids using Figo type for consistency. Think in ESG terms if you are going for hysteroscopy cases. Route choice, hysteroscopy myomectomy for Figo 0 to 3, abdominal myomectomy for Figo 3 to 7, and selected large type 1 to 2 fibroids. So this is the material which I have taken. Individualized care, guideline adherence is important, shared decision making is very, very important. Thank you.